Hello, everyone, and welcome back to Dementia Basics. This is part 4, our fourth video, and thank you for watching again. During the previous section, called The Signs of Dementia, part 1, 2, and 3, you learn about the structure of the brain and how those changes in our brain could potentially lead to Alzheimer's disease and other types of dementia. How research is our main tool to find a possible cure for Alzheimer's. Now, we're moving into a new section, and this is about understanding and management of behavioral and psychological symptoms of dementia. You will gain knowledge about those symptoms. You'll be mindful of those symptoms and behaviors that a person with dementia could have, and that making the right assumption could help that person to have a better quality of life. Those unmet needs that could potentially be part of the symptoms as well. In this video, Dr. Lisa Sweet will discuss and explain in depth the different symptoms and behaviors of a person with dementia. I highly recommend you to watch this presentation in advance and get ready for the Q&A, the live Q&A on July 5th at 6 p.m. So I'll see everyone later.
In response to a psychological experience, oftentimes to get a sense of what's going on psychologically or emotionally, we have to rely much more on information that the patient might give us. So we're going to talk to them, ask them how they're feeling, ask them what's going on, ask them, are they anxious? Are they sad? Are they depressed? That's what we're going to explore, as well as getting information from close contacts, people who know the person very well, who might be able to say their loved one does seem down or depressed or is sad because they're seeing some of those symptoms. So that's sort of how they're divided, behavioral and psychological. And then here on the next slide, you have a bit of a list to kind of illustrate what some of the examples could be for those different types of symptoms. So when you look at the behavioral symptoms, again, it's things that we can usually witness or see or experience. So there's things that agitation, disinhibition, obsessive compulsive behavior, so repetitive actions or repetitive thoughts. There can be verbal aggression, physical aggression, maybe escalating to physical violence, disturbances in eating, sleep disorders. People can start cursing. There's shadowing. Shadowing is when the person with dementia is kind of following their caregiver quite closely. That's one of the behavioral symptoms. You can have crying and probably dozens more. But those are the main ones that we see. On the psychological side, you can see things like depression and anxiety are always there to look for. You've got apathy, and we'll talk about that a little bit later. The distinction between apathy and depression, because they can look quite a bit alike. Euphoria doesn't happen a lot in dementia, but it's kind of that really elevated mood, feeling particularly great. It can happen. Irritability is a very, very common one that comes up. And then the more, if we want to call them more psychiatric symptoms, the hallucinations or illusions, we'll talk about those as well, and delusions, which are beliefs that are not grounded in reality. The hallucinations, for those of you who don't know, are seeing things that are not there or hearing things that are not there. Most often, though, in dementia, we're going to talk about visual hallucinations. So I'm going to touch upon all of those different examples as we go through the slides. But in very broad terms, kind of that's the division. And that's the type of behavioral and psychological symptoms that might most often come up in the context of dementia. Okay. It's really hard when you don't see your crowd. Hopefully everyone's following along. Don't be shy to use the wave if you need to. All right. So what you have on this slide here are the what we call the DSM, so the Diagnostic and Statistical Manual of it's the manual we use to make diagnoses. So it's groups of psychiatrists, psychologists, researchers who have come together over the years to put together, based on research and studies, what are the criteria that you're looking for to make a formal diagnosis. And as you can see, this is called DSM-5. So this is the 5th iteration of these diagnostic guidelines. And as a matter of fact, with this new version, they took out the word dementia, though for us, it is still what is meant. And what the term used now is one called major neurocognitive disorder. And you'll see as we go through, I'll review the criteria with you. They don't really talk about specifically behavioral and psychological symptoms as being part of the diagnostic criteria, though we know for us it can come up. So you probably know this, or maybe it was discussed in the previous talks, but basically to diagnose someone with dementia, you're looking primarily for significant cognitive decline from their previous level. And this can occur in different domains, whether it's attention, what we call executive functioning, learning and memory, of course, language, perceptual, or social cognition. And I would say the behavioral or psychological symptoms that we might see as being part of the diagnostic process for dementia would fall under things like the executive functions and the social cognition. People can describe changes, and we could make them fit under those categories to use that as part of the diagnosis if we feel that that's what that the dementia is driving the presence of those symptoms. So you'll see that's pretty much the only place where it's mentioned, because a lot of the focus on dementias and most of the dementias is really on the cognitive changes that happen, especially at the diagnostic level. And we know that the other issues can become quite prominent as time goes on. Okay, so the reason why it's important to discuss these features or these symptoms in addition to the cognitive symptoms, cognitive meaning attention, memory, thinking, is because they are quite prevalent. They're quite common in dementia. So you'll see here on this slide, we talk about 40% of patients with MCI, which is called mild cognitive impairment. So it's before they reach that stage where we would call it a dementia. You might see some of the behavioral changes or psychological symptoms as early as in MCI, but still only about 40%. As you get through the early stages of dementia, we can see those symptoms kind of come up more often, somewhere in the vicinity, give or take, of 60%. And at some point or another, whether it's in the early stages, moderate stages, or late stages, at some point or another, we expect that somewhere upwards of 95% of our patients with dementia might experience or exhibit some of the symptoms we're going to talk about tonight. So it is quite a significant issue. It does come up more often as the dementia advances. So, I mean, you can see from the numbers, 40, 60, 95. It's usually in those more advanced stages where the behavioral and psychological symptoms will be more pronounced, though they can occur earlier on. These types of issues will fluctuate. So fluctuate in that what is a problem, say a behavioral symptom that comes up in the middle stage, might not persist into the later stages. It might dissipate or disappear, and a new set of troubles might appear. A new set of symptoms can appear. So it's a little bit less predictable than the cognitive changes. We know, though we can't always estimate the rate or how someone will progress, what we do know in dementia is that whether it's Alzheimer's and their memory disturbances, memory problems will just very slowly, progressively get worse over time. It won't be as fluctuating as the behavioral and psychological symptomatology, which can be quite changing throughout the whole course of someone's dementia. It also is important for health professionals to really be aware of the behavioral and psychological symptoms, because they are often more problematic than some of the cognitive problems. And they really, really contribute to the state of disability of the individual. Whereas their memory might not be so bad, but if they become profoundly depressed or very anxious or maybe a little impulsive and hyper-focused on certain things, that's going to create greater disability and reduced function. So it has an important contribution to the problems that they might encounter in everyday life. They're also related to more difficulties for the caregiver. It ends up creating a greater burden of care. So if left unchecked and unsupported throughout the course of dementia, we're more likely to encounter poor caregiver outcomes. A caregiver can become depressed and stressed, oftentimes because of the compounding effects of these behavioral and psychological symptoms. These type of symptoms also often, unfortunately, contribute to early placement. They're often the straw that might break the camel's back, where it's just impossible for the person to, or the caregiver, to continue caring for their loved one, either in their home or in a less structured environment. So they might seek placement sooner. Also associated with higher care costs. If we're seeking placement more earlier, that's a higher burden on the healthcare system. If you're looking for, or if you need more direct care, so if a caregiver can't leave the person unattended because of some of the behavioral or psychological symptoms, they might need to have someone stay with them, or in long-term care facilities, we might have to hire sitters to just be present and be kind of a stabilizing presence for the person. That all leads to increased costs. They're also often the triggering event for a referral to a specialist, right? So family physicians are very well trained and very good at, identifying dementia, initiating what is considered kind of first line treatment, medication for perhaps more textbook forms of dementia. But when things start getting complicated and we start getting into behavioral issues and those psychological issues, they're going to more often call upon a specialist. And that specialist often is a psychiatrist, or maybe a dementia coach, or we're just going to draw on greater expertise to try to help the person with dementia and their caregivers and family. So these issues become very important and contribute a great deal to the healthcare and the stress that might be experienced by a caregiver. So this slide here illustrates or starts to give you a sense of how it's virtually impossible for us to draw up or predict what will be the individual's personal profile of behavioral and psychological symptoms. Each one is unique and will depend on so many factors that when people ask me, well, what can I expect? I can tell them in broad terms, much as I'm doing tonight, what comes up more often, what might be some issues they might face, but there's no way for me to predict what each individual might struggle with or when it might come up. And the reason for that is, as you can see along the sides, many different reasons. First up, the type of dementia the person might have. So we're going to talk later on about the different forms of dementias and how the behavioral and psychological symptoms might manifest themselves differently in particular forms of dementia. So somebody who has Alzheimer's disease might not present with the same issues as somebody who has Lewy body dementia. Likewise, somebody who's at a different stage in their dementia, so as we talked about a couple of slides ago, somebody who's in the mild cognitive impairment stage, or somebody's in the mild or moderate stage, might not have the same symptomatology as someone who's in the severe or more advanced stages. Comorbidities are things that coexist with the dementia. So people come with other health issues that they might have. They can be medical issues and they can be psychological issues. Before we age and go on to develop dementia, possibly for some of us, we have had years and years of a previous life where we have perhaps struggled with depression or struggled with anxiety outside of the context of a dementia. Somebody might have diabetes, a number of things that can cause additional problems or complications. At the top on the right, you'll see there's brain reserve. Reserve, or what we know of as cognitive reserve, is what were that person's strengths when they may have started to develop dementia, and how are those strengths helping them, or maybe giving them a means of compensating for some of the difficulties they might be having, so that those symptoms don't become quite as problematic just yet, or as soon as perhaps someone who has less cognitive reserve or fewer cognitive strengths than someone else. Premorbid personality. We all have a personality, and that's going to affect how the person experiences or manifests their dementia symptoms. And last but not least, of course, is the environment. Everyone is in a different environment. There's different family circumstances, housing circumstances, how a home is set up. There's numerous variables in the environment that will affect how or what behavioral and psychological symptoms might appear. Okay. All right. So this is kind of the same idea, perhaps in just greater details. Same notion, though, is just to highlight that so many factors can come into play in creating what here on the top right are the behavioral and psychological symptoms of dementia. So as I mentioned, you have the neurodegeneration. So over here on your left, you'll see the slide that says neurodegeneration associated with dementia. You're going to have disruptions in brain functioning. That is going to make the person more vulnerable to stressors that they may encounter. When you can't remember as well, when you can't focus as well or process information as well because of the cognitive changes of dementia, you become more vulnerable to the stress of what's coming at you from the outside demands, whether that's a conversation, whether that's interacting with the clerk at a store, whether that's overseeing your finances, going through paperwork. All of those things are more likely to create stress because the person can't figure them out as easily. Added to that stress are the things that we talked about. So the patient factors, as I mentioned, the personality or previous psychiatric illness, acute medical problems, so people can become sick, they can get infections, urinary tract infections, pneumonia, people can become dehydrated. Constipation is a big factor in terms of making people kind of behaviorally more agitated. And that whole notion of the person with dementia having unmet needs, and we're going to talk a little bit more about that, those unmet needs as fueling that vulnerability to stress or becoming stressful and leading to increased behavioral and psychological symptoms. The caregivers are, to me, an integral part of the environment. So Caregivers can become stressed, can become anxious, can become depressed, can become angry, can become frustrated, and that's all going to affect how, as a caregiver, one responds to a situation, whether it's a behavioral symptom or a situation. That's going to have an impact on how the person with dementia also responds. We can see sometimes that lack of education about dementia, a lack of understanding. Let's face it, most of us, until we're confronted with a health situation, we often don't know that much about it. When we are interested in our health and you get diagnosed with diabetes and you want to know more about it, you can become an expert in diabetes. But until then, you're kind of floundering around and not really sure about much because we never really had to learn about it. So learning more about dementia allows caregivers and family members to be better prepared. How we communicate, and oftentimes this difficulty with matching the expectations we might have of a person with dementia, and how our expectations sometimes have to change because they are no longer compatible with where that person's at in terms of their dementia severity or their cognitive decline, and having to adjust that, because if there's a mismatch, again, that just creates stress. The last square here down on your bottom right, the environmental factors. As I talked about, there's many different things that can show up in the environment, including a situation where the person might be overstimulated, understimulated, safety risk factors in the home, and lack of activity or structure or lack of routine. All of those things can provide an opportunity to increase stress and lead to more behavioral and psychological symptoms in the person who is suffering with dementia. Okay, all right. So the purpose of sharing all of this with you guys is really based in social psychology, and it's really this sense of attribution. We do it every day in numerous circumstances every day, and dealing with someone with dementia is no different. It's really how we explain someone's behavior or to what we attribute it to is really going to affect how we react to it. It's not a perfect thing, but the more we know and the more we can take a step back and say, okay, it might be because of this, it might be because of another factor, it just allows us to not automatically feel that we are attributing it to the individual. So this example is just a driving example, right? You're driving along in traffic and somebody does something negative, either cuts you off or something like that. And if you're going to attribute it to the situation or be willing to consider other factors, one hypothesis might be, well, hey, that guy might not be feeling well. Maybe something's wrong. People who can think that way are usually much more tolerant. You're able to say, okay, there's something going on. I will just let them do their thing and not let it get to me. Somebody who's more likely to not try to think of other hypotheses, you're going to more likely attribute it to the person. That person's crazy. That guy's an idiot. And that leads to feeling angry and frustrated, and the reaction is more likely to be unfavorable in that circumstance than calm and more tolerant. So I'm not saying that after after this talk that it makes it easier to deal with things. It just gives you more opportunity to think of other reasons as to why something might be happening. And by considering other reasons, there are at times where that might open up some opportunity for change or moderating the behavior a little bit. Okay. So that's kind of the premise of why we're doing this, to help review, because when you don't understand what's going on and we make the wrong assumptions, patients or persons with dementia can become labeled as non-compliant, as irrational, as uncooperative, and there's a much bigger picture, and just always trying to think of all the different hypotheses as to what might be going on just gives us more opportunity to act on it and try to help it a little bit. Okay, are there any questions so far? Should I check? Are we good? Okay. All right. So we're going to talk a little bit about the brain. I said we weren't going to talk too much about cognitive functioning tonight, but I just want to talk about kind of the main centers of the brain. And I think maybe you guys might have seen them in the previous talks for those of you who had the other first 3 parts of the series. But just to touch upon mainly, really to emphasize how everything is so connected, and how all that interconnectivity between those different parts of the brain and the functions that they affect, as really creating this complex situation, and creating many layers as to why someone might be acting or behaving or feeling the way that they are. So we're just going to touch upon here on this slide. We have the frontal lobe, which is the last one to develop as we mature. And oftentimes, though, unfortunately, the first one that gets disrupted in many circumstances. Our frontal lobe is responsible for many important things. We refer to it as the brain's CEO. Without it, it would be very hard. We would be much more primitive than we are now. It helps us with decision making. It's how you can figure things out and anticipate what might happen. It helps us regulate our social and emotional behavior. It helps us with appropriate inhibition, that filter that's on, how sometimes we don't say what we think because we know that the outcome that we're anticipating is going to be a bad one, and it's best to leave it unsaid. Emotional processing, it allows us to plan and organize. It allows us to be flexible. If something's not working, we can go to plan B. We can set up goal-directed behaviors so we have a purpose. We want to get from A to B, and we know what has to happen in between. And we're aware of ourselves, and we have that insight of did I handle that well? Could I have done better? Am I doing okay? Did I remember well? So we have that self-awareness. A lot of that is processed by the frontal lobes, but they are not alone, and they are heavily connected to all the other parts of the brain. And this is just a very basic illustration of the different lobes of the brain. Of course, the temporal lobe down here on your right is very important for our memory, our hearing, understanding language, processing information. Down below here, the brain stem is what keeps us alive, our breathing, our heart rate, arousal, our sleep and wake cycles. The cerebellum at the back, we know, is very important for balance, coordination, some cognitive activity as well. Your vision is highly dependent on the occipital lobe at the back. And the parietal lobe is a lot of the sensory, so sense of touch, awareness of the spatial relations, academic functions such as reading, mathematics, things like that. But they're not isolated to those areas. Think of a lot of wires going between all of those parts of the brain, and how each, a loss in one can have an effect and an ability that it is related to, even though it might not be primarily responsible for. So when things like dementia start to happen, a dementia may happen or begin in one part of the brain, but as it expands and as the disease progresses, often other areas or other circuitry is going to become affected, which is why you start seeing broader symptomatology, whether it be cognitive, behavioral, or psychological. Just more disruption occurs, so you're more likely to see more symptoms as the disease progresses. Okay. All right. So, as I mentioned, neurodegenerative dementias affect different brain areas, and we'll talk a little bit about that later as we talk about the more specific kinds of dementia. In more advanced stages, you'll have more widespread pathology, so more disruption of all the different networks. And as those things start to miscommunicate between one another, you're going to get a greater degree of behavioral and psychological symptoms in someone with dementia. So this slide here, so we've just talked about how the brain structures can become affected. So we know, for instance, as a neurodegenerative disease sets in, there's a destruction of brain tissue, of nerve cells, of brain cells, and there's loss of tissue there. What we can see is what we call atrophy in certain parts of the brain. But not only, even if there's perhaps less tissue loss, you can also have dysregulation at the level of the chemical neurotransmitters. So not even just kind of the size or the bulk of the brain, but how those parts of the brain talk to one another can be disruptive. So in our brain, our nerve cells talk to each other by neurotransmitters, and you can see in the middle, one nerve cell will talk to another here by releasing a neurotransmitter. It goes to the other nerve cell, creates a reaction, and then they talk to each other that way, and it goes from one to the other. And there are several types of neurotransmitters. Here on the slide, you have 4, and how each one of those has a role, a greater role in certain areas. And so if you see disruptions in some of those because of dementia, this might be why some of the symptoms appear. So one of the main neurotransmitters that we have is serotonin. Serotonin helps to regulate our mood, our sleep, our appetite. It helps, a proper level of serotonin can help reduce depression and can help regulate feelings of anxiety. That's why a lot of antidepressants are SSRIs, serotonin reuptake inhibitors, because serotonin is very important in that. If someone with dementia is experiencing changes in their brain, which is causing some changes in how well or how much serotonin might be available, we might start to see some of these difficulties. Likewise, you have dopamine. Dopamine is very important in motivation and reward. It's important in mood as well. It's important in desire. It's important in voluntary movement. So that's why people with Parkinson's disease are treated with kind of dopamine type medication, because it's involved in voluntary movement. It's also involved in cognition. So if you start seeing changes in dopamine levels because of a dementia, well, the person might experience some changes in their movements, and that can happen in something like, say, Parkinson's disease. You might see change in their level of motivation as one reason why their behavior might be changing. Norepinephrine is another neurotransmitter. It's involved in kind of keeping our energy level up, our level of attention, some aspects of cognition. It's very important in a stress reaction if we need to flee, or the fight or flight response, and also regulating depression as well. So again, if you see changes in norepinephrine, you might see changes in the person's behavior or their psychological profile. Acetylcholine is very important in attention, memory, and learning, and it is kind of the key hypothesis that we're working with in trying to treat Alzheimer's disease. And the medications you hear about, whether it's Aricept or those types, try to act on the cholinergic system. So try to help influence the level of acetylcholine that's available in the person's brain to try and enhance what might be missing in terms of attention, memory, and learning. So these are just 4 very basically described kind of neurotransmitters that, just to illustrate that not only are there changes kind of at the physical level in the brain, but also at the chemical level, which can influence the symptoms that the person might manifest in the course of their dementia. Okay, so we've just pulled together a couple of testaments or kind of anecdotes from people who have dementia, just so we can get a feel of what it might be like for them to experience things and what might prompt a behavioral or a psychological symptom. So this is something that a woman who is 61, Wendy, had written down in her blog. This feeling I can liken to a necklace being all tangled up and having to sit there and untangle the knots. You feel panic rise inside of you and you find it impossible to work out what day it is and what you're supposed to do. So you feel stuck, right? And on these occasions, it can feel like your head wants to explode as you feel out of control. So it touches upon sense of panic, anxiety, wanting to explode, feeling out of control, feeling confused. You put all that together, and that's sometimes why we see the behavioral and psychological symptoms that we do. This is another statement written by a person named Rick, who was diagnosed with early onset dementia. And he says, imagine yourself in a strange building, one you've never seen, surrounded with items you've never seen. Then one by one, people who are complete strangers to you begin to enter this room and talk to you as if you've known each other for your entire life. This simple scenario doesn't even begin to show what a dementia patient goes through. So that sense of fear, uncertainty will certainly fuel how someone responds to a situation like that. Okay. All right. Moving along. As a healthcare professional, one of the things that we have to be very vigilant of is, before we assume that the person with dementia is exhibiting behavioral and psychological symptoms related to their dementia, we want to make sure that it's not a delirium, because a delirium can be treated and hopefully reversed, and you might actually see those symptoms remit and go away because they weren't necessarily part and parcel of the dementia. They were secondary to another process. So delirium is quite frequent in people with dementia. They become at higher risk of experiencing delirium. Their brain is already in a more vulnerable state. So things that happen within the body, whether they're medical, metabolic, things like that change, the person is more likely to be impacted by it, and you can see an acute change in their status. And when a person becomes delirious, they can experience or express many of the symptoms that are similar to the behavioral and psychological symptoms of dementia. They can become confused, they can become irritable, they can be disruptive, like say somebody's in hospital, they might be pulling out their IVs, they might be more labile in their mood, they can hallucinate, they can become delusional. All of those things can happen in delirium, but a delirium can be reversed. And what we look for is a little bit of a different profile. So it'll often come on very suddenly. It'll be an acute change. We will see that the person's attention or their level of consciousness might not be, they don't seem as alert. Their thinking might seem more disorganized than typical. And as I said, an altered level of consciousness. So they might not just be as alert as they were before. And if that were to happen, usually a family doctor or whoever the physician in charge or nurse practitioner, whoever's following the person, will look to rule out something that could be causing a delirium. Very often that's a UTI, a urinary tract infection, that can precipitate delirium. Maybe the patient has had new medication changes, sometimes medications not even related to their dementia. So if there's new medications on board, they will check and make sure the person's not dehydrated or malnourished. They'll do blood work to check for metabolic disturbances. So whether it's, they'll check their calcium, they'll check their sodium, make sure all of those things are good. Thyroid, vitamin B12, you want to look for everything. Just to make sure there hasn't been a sudden change that would have precipitated this. Recent surgery with anesthetic and pain medication can sometimes precipitate a delirium. And so the important part is making sure that there isn't one of these things that have happened or underlying the sudden change, because if it's a UTI and you treat the UTI, a lot of the symptoms that you're seeing might get a whole lot better, a lot quicker, without having to use, say, psychiatric medication, because you've really tackled the cause of it in the first place. So that is kind of the number one rule, is when there's a sudden change and the person is expressing kind of an acute change in their symptomatology, number one is rule out a delirium, even in the more advanced stages of dementia, because even there, sometimes you can see kind of a rather sharp change in someone compared to, say, the week before or the day before. And if it persists, you want to make sure there isn't something you can perhaps more easily treat or address. So I mentioned earlier, one of the excuse me, one of the models as we try to understand what might precipitate someone's behavioral or psychological symptoms in the context of dementia. There are many models that have looked at this and different theories on what might be fueling the person's difficulties. But one of them is what we call the model of unmet needs. It was first proposed by these researchers here, Cohen Mansfield, back in 2009. They did a study on 89 residents in long-term care to see what could explain some of the behavioral and psychological symptoms that they were seeing in those residents. And they used a bunch of different observations and questionnaires, and a number of factors have come up. But the unmet needs that came up the most often, out of the 89 residents, many of them had at least 3 unmet needs on average when you assess that person. And the 3 main ones that come up are boredom and sensory deprivation. So if the person's bored, you're more likely to see problems. Loneliness and a need for social interaction is often another unmet need that the person might be experiencing, which might be fueling some of their difficulties. And looking for a need for meaningful activity. Those were the 3 kind of unmet needs that they identified most often in those residents as being one of the big driving factors in some of the problem behaviors or symptoms that were being exhibited by those residents. Okay, so, and we will talk a little bit more about those as well. So I mentioned at the beginning that we want to study the behavioral and psychological symptoms of dementia because they come up so often. This particular study, now the numbers might be different. I always tell people, the percentages might be different from one study to the next. These are a few studies, but generally the trend is still the same. So this group looked at 107 patients, and nearly all of them, 99%, had at least one behavioral and psychological symptom of dementia. It might have been mild, it might have been moderate, it might have been severe, but most of them had something. And 71% So almost 3/4 had more than 4 symptoms of the behavioral or psychological symptoms that we've talked about. So it is very prevalent. It's very problematic. It's a huge factor for caregivers and health professionals alike. Some of the most frequent ones that come up, as we talked about earlier on in this study, apathy can come up, and we're going to talk about apathy. Agitation is a common one, irritability, sleep and appetite disorders, mood disorders. And as I mentioned earlier at the beginning, euphoria is not very common, and it was not very frequent in this study as well. We're going to talk about the different forms of dementia, the behavioral and psychological symptoms, and I would say probably more the behavioral symptoms will probably be highest in frontotemporal dementia and early on in frontotemporal dementia, and we will talk about that. Dementia with Lewy bodies is a close second. In their study, they didn't mention Alzheimer's disease, but certainly we will talk a lot about that one, as it's kind of the most common form of dementia and certainly has very frequent behavioral and psychological symptoms. The least seem to be in the context of vascular dementia, probably because it's the hardest one to predict. With vascular dementia, it depends on where the vascular injury occurred. And we will talk about vascular dementia shortly. As I mentioned earlier in this study, it kind of corroborates what we saw earlier on, in that the behavioral and psychological symptoms become more prominent with increasing severity of dementia. And all of those, as they increase, they cause higher caregiver distress. All right, so this is just a slide to illustrate that. Now, this is in Alzheimer's dementia, so it's just Alzheimer's. You'll see each, so on the bottom part here, you have the different symptoms that the person might experience, and the bars are mild level dementia. So people with mild dementia are in the clear white bars. People who had moderate dementia are in the gray bars, and those with severe dementia are the ones in the kind of darker gray black bars. So you'll see that in most circumstances, except maybe for hallucinations, but in most circumstances, as you get more severe dementia, that problem will be more prominent than it was in persons with mild dementia. So this just kind of goes to show, and the ones, as we get into the more, in the case of Alzheimer's disease, as you get into the more severe stages, you're going to get the agitation, or the reverse, the apathy, irritability, and aberrant motor behavior. Aberrant motor behavior is things like wandering, disrobing, aberrant behaviors such as that. So this just shows, and it just kind of illustrates, I think, how those rates go up as the severity of the dementia increases. All right, so let's talk a little bit about apathy. Apathy, so without, and pathy, without emotion. So apathy is really that absence of emotion. It's a flatness to the person. There seems to be a loss of motivation, a loss of interest in activities. Their emotional responses are blunted, they're flat, they're not particularly sad, they're not particularly happy, they're just flat. There is this sense of indifference, and there's a loss of motivation and therefore initiation. So somebody who's apathetic is very hard to get going. They might sit and do very little all day. And that can become very difficult for caregivers. They don't seem interested, they don't seem to care, and they don't initiate anything on their own. You have to structure everything for them, get them going, and kind of move them along throughout their day, as you get very little interest or response to any suggestions. It is one of the dominant features that you might see in Alzheimer's disease. Again, kind of maybe less so in the mild stages, so maybe somewhere in the order of 40%. But as you get to the more severe dementias or the more severe stages of their Alzheimer's disease, it can come up quite often. So apathy is one significant symptom that caregivers struggle with. And here what I want to highlight is the distinction between apathy and depression. Now, they can be hard to distinguish because, as you'll see here in the middle, there is a great deal, or there are a great deal of overlapping symptoms. And sometimes we're not really sure. You want to spend time with, and as I mentioned, when we're looking at the psychological symptoms of dementia, we have to spend time interviewing the person, trying to see how they're feeling. Can they express what's going on, or what are other people seeing, to try to get a sense of, well, is this depression or is this apathy? And there's this overlap, but apathy is really a disorder in the motivation of the person, whereas depression is a disorder, it's an emotional situation, it's an emotional symptom, it's a disorder of their mood, not their motivation, and possibly more amenable to treatment or intervention. So if the person is apathetic, we might have fewer options in terms of, say, pharmacology than if we're dealing with depression. So we will spend oftentimes a great deal of time trying to sort those two out. So in the middle, in terms of the overlapping symptoms, people will get slow. So psychomotor retardation just means that they are very slow at thinking, they are very slow at acting, very slow at moving, just do things very slowly. Anhedonia means there's just no pleasure. They just don't seem to experience any joy. Anergia is a loss of energy, so there's less physical activity. They're not enthusiastic, even about things that they used to perhaps enjoy or quite like doing. And that's going to be common to both of them. What will characterize depression, perhaps more than apathy, is there is an emotional, there is a sense of sadness. It's not a flat or blunted emotion or a lack of emotion, it's a very negative one. So the person might express feeling sad and tearful. They might express feelings of guilt. They might have negative thoughts about themselves, about their future, about their situation. They can express feeling helpless, a sense of hopelessness, pessimism, suicidal thoughts. There's a valence to the emotion, except that it's a negative one. That's much more characteristic of depression than the indifference or the lack of reactivity or the lack of concern or the reduced initiative, which is much more behavioral because it's a disorder of motivation, that you'll see in somebody who is perhaps simply experiencing apathy as a result of their depression. So even someone who is in, the mild, moderate, maybe even, if we can, sometimes the more advanced stages, if they start seeming apathetic or unmotivated or disengaged, it's important to explore the side of things that could identify a depression that we would want to tackle and try to treat, as opposed to implementing maybe more behavioral guidance around the apathy symptoms. So an important distinction for clinicians to make, and one that's not always easy on the first go. Sometimes it takes some time to sort those things out. The other thing is apathy and inability are also different. Somebody who's apathetic or suffering from apathy will, of course, not initiate a lot of activities and will rely on others to prompt their behavior. And you lose a lot of independence when you're suffering from apathy, because if you don't have someone around you to promote your engagement or structure your day or point you in the right direction, you're not going to accomplish as much. So there's a loss of independence there. But sometimes it's not because the person has necessarily lost that particular ability. And when structured and set up to do the activity, they can actually do it okay. They just lack the motivation or the ability to initiate it. And that's where sometimes we can get that disconnect between, or the difficulty in figuring out, okay, are our expectations fair given the person's level of dementia? So I always try to say, okay, well, let's see if the person is able to do it. And if it's just apathy, structuring them and letting them do it and, experience some success or achieve a goal for the day. But if they are unable, then that's different, because they are going to need assistance to do it. And no amount of pushing them or structuring them might result in success. So to the extent possible, we encourage people with dementia to remain active. And the more active they are, the less caregiver burden might be present, but at the same time, trying to always be sensitive to the fact that there may come a time when that particular ability is lost and the person won't be able to engage in that particular activity. Okay. All right. The other important distinction, so we talked about apathy and depression. Of course, we also have to sometimes try to distinguish between anxiety and agitation. Anxiety can certainly lead to agitation, but agitation sometimes might have different causes. So again, we spend time talking to the person to try to figure out, are you feeling anxious or worried or stressed about something that they can somehow articulate to us? It might be worry about the future. It might be worry about their finances. It might be worry about their spouse's health, their children, their grandchildren. So we want to explore and see if there's an anxiety element and something that we can help them through. You might deal with that a little differently than somebody who is agitated. Agitation here, you'll see here, it's just this excessive purposeless motor activity due to some form of inner tension. And sometimes the more agitated someone can get, it can lead to some aggression or some of those behavioral expressions of frustration and anger that a person with dementia can experience if their agitation grows and grows. So we will spend a lot of time kind of talking to people to the extent that they can, depending on the stage of their dementia, on is there something worrying them? Is it fearfulness of something? Are they nervous about something? To try to get at, anxiety and agitation, and where do we want to focus our intervention efforts. This next slide here, one of the other kind of behavioral or syndromes that we can see in dementia, and some of you might be well familiar with it, is called sundowning. Sundowning is just an expression, we call it sundowning because it happens a lot more in the evenings. It is this level of increasing agitation and confusion that can start to happen throughout the day. It becomes more prominent in those late afternoon, evening hours, where the person with dementia can become quite confused, quite anxious, more aggressive, a little agitated, and restless later on in the day. The phenomenon of sundowning tends to occur more in the middle stages. It's not something I would expect to see someone experience in the early stages of like mild cognitive impairment or very early stages of dementia. We don't normally see sundowning. It would be something you would see most commonly in the moderate stages of dementia, and sometimes it dissipates as you get to the more advanced stages. So it might become less of a problem. As I mentioned at the beginning, some things that are a problem at the beginning are less of a problem in the more advanced stages, and vice versa. So sundowning more common in the moderate stages of dementia. Why it happens, you'll see here at the bottom, there's different contributing factors, things that seem to be more likely to provoke a sundowning response in someone. People get more tired at the end of the day and fatigued, so it's harder to cope with what's expected of them, or kind of the remaining activities that are left throughout the late afternoon and evening. There's also often low lighting, which can lead to some confusion or misperceptions or uncertainty in the environment. One of the biggest things is the internal clock disruption. So there are disruptions in that circadian cycle of sleep and wake, and it's harder for them to distinguish night from day. So somebody might be calm throughout the day, and then comes 6:30 p.m. might become very agitated, very aggressive, might start to wander, try to leave where they are. So exit seeking behavior can be ramped up, and that can go on sometimes through the night, which is very, very difficult for a caregiver and health professionals who are caring for those individuals. That is sundowning, and the different factors that can cause it. But it's a fairly common syndrome that we will see, though probably not before the moderate stages of someone's dementia. But it can happen in somewhere in the vicinity of 20 to 45, maybe even as high as 65% of patients. So again, a very common issue that caregivers will struggle with. Okay. So I've already covered this. So as I said, tends to peak in the middle stages, and here are some of the behaviors you can see. And of course, all of this, as someone becomes more agitated and perhaps aggressive, they're going to become more resistant to care. So things like dinner time, bedtime routine, nighttime medications can all become quite difficult if the person is experiencing sundowning. I wanted to touch upon just a few more specific symptoms of, if you will. Wandering is one of them. Wandering comes up quite a bit in the context of moderate to advanced dementia, and it's one of the most troublesome of symptoms. It's often what will provoke the family or caregiver to seek admission to long-term care, because the safety of the individual is just too difficult to assure from day to day. And wandering can include aimless walking, exit seeking, so trying to go out and attempting to leave the house. So it is a very common and problematic behavior that we see in dementia. The reasons, again, might be varied and might be different from individual to individual, but certainly because of some of the brain changes they might experience, there might be difficulties with their navigation, kind of their wayfinding, where they are and how to get somewhere. It can be boredom at times. They might be anxious about something, or they might have a false belief. They might feel they need to get somewhere and incorrectly believe that to be true and want to seek out achieving that activity, although it is a false one. So just a few little notes on wandering. Okay, so here is, I probably should have put this slide closer to the, when I talked about depression earlier on. But depression does come up often in Alzheimer's disease as one of the psychological symptoms of dementia. It's often an early symptom, and we'll look for kind of depression and anxiety in someone who might have never experienced that before. When family members start talking about how mom or dad or their spouse is suddenly way more anxious and more vulnerable to feeling sad without any obvious reason, when they never had a history of such problems, that might pique my interest a little bit in terms of, okay, maybe this is all part and parcel of what's going on in a much bigger issue. So it can be an early symptom. Some of the risk factors, it doesn't mean that it's guaranteed, but it might happen more frequently in women. Somebody who may had a previous history of depression may be more likely to experience it. And younger onset dementia might experience depression more frequently than perhaps your more classic onset of Alzheimer's disease, which is later in life. In many patients, though for some it can be early on a reaction to the diagnosis, in many patients it's part of the syndrome and not just a reaction to being diagnosed with Alzheimer's or even another form of dementia. Earlier on, we saw where those neurotransmitters can be disruptive, and as they're disrupted, they can have an impact on things like mood and anxiety. So those disruptions can provoke those symptoms of depression in persons with dementia, not necessarily because of how they're reacting to being told or what they're dealing with. But having symptoms of depression on top of perhaps the cognitive symptoms of one's dementia or Alzheimer's disease as well is just going to further complicate their daily functioning. It's going to increase problematic behavior. If it gets really bad, it's going to increase nursing home placement and increases caregiver stress. It's just one more symptom to add to an already often complex symptom profile that's just going to make things more difficult to manage day by day. So earlier on, we talked about the difference between depression and apathy, and as both of those can be a behavioral and a psychological symptom of dementia. Here I'm drawing the distinction between depression and Alzheimer's disease or dementia. That too, much like at the beginning when I mentioned the importance of distinguishing between behavioral and psychological symptoms of dementia versus delirium, we also need to be on the lookout for depression and how it might be different from dementia. Because depression, if it's only depression and not depression with dementia or dementia with depression, we have more likelihood of possibly successfully treating the depressive symptoms and having the person improve, rather than a neurodegenerative dementia, which we know will be slowly progressive. So again, in the middle here, you see how some of the things will occur in both, right? So there'll be a set of symptoms that will happen in somebody suffering from a major depressive disorder and somebody suffering from dementia. But what will distinguish them is often in depression, it will have a faster onset. You'll have, as I mentioned earlier, that sadness that we're going to go and see. Is that person experiencing sadness? Often people with depression, they're functioning a little worse in the morning. It's harder to get going. It's harder to get motivated. But with depression, if you can get going, sometimes it gets better throughout the day, as opposed to dementia. We had said in certain stages of dementia, they are worse in the evening. There'll be those sentiments of guilt that I mentioned we would interview for, suicidal thoughts. And those symptoms, if what the person is dealing with is just a depression, and I don't mean just, I just mean no other comorbid neurodegenerative dementia, you're more likely to get a response to antidepressant treatment and hopefully relieve some of these symptoms and get the person back to their baseline. In dementia, we traditionally say that the onset is much more gradual. People will come in, oftentimes by the time we see them, the person has been kind of experiencing symptoms for at least a year, sometimes two, and it was always very gradual and subtle before it reached a point where it was like, okay, this is clearly getting worse. We need to have this looked at. It's much more gradual. The other thing that people with dementia will experience are language difficulties. We all experience word searching. We all sometimes block on a name or a word. It is probably the most common complaint I hear, even in my perfectly normal, healthy adults once we're done testing them. Whereas it's a very common complaint, it's actually not a very common finding. So if I find in my assessment language difficulties, whether it is true word finding problems or what we call anomia, or real fluency problems, that give me a sense that there is something happening in the language system, I am much more likely to think that something's happening in that person's brain, whether it be a form of neurodegenerative dementia or vascular change, something rather than depression. Apraxia is what we look for. It's kind of a loss of the ability to do well-known coordinated movements. So the person will just seem very awkward. Later in dementia, you'll see problems with dressing. So putting clothes on backwards, not being able to button them up right, troubles using cutlery, utensils, tools. It's not a common complaint because it's not something we see in the early stages of dementia, but it is something that we look for. And if we find it, we certainly think of something much more neurological rather than psychiatric. And disorientation as well, not being able to know the date or what's going on today or tomorrow is much more characteristic of dementia. And dementia itself will have less of a response to SSRIs or antidepressants, though we do often give antidepressants to persons with dementia. It can help with other symptoms. It won't help like the motor or the language difficulties won't be treated or won't respond to SSRIs. So these are some of the characteristics that will allow us to try to distinguish kind of, is the person depressed or are they struggling? Is there a new disease happening in the person's brain? All right, so normally if we were together in a room, we would be taking a break right now. I suppose it's a good time to check and see if there are any questions or if I'm doing okay or missing anything. Or maybe, Arman, I don't know if we actually do normally take a break, if we give people a few minutes and...
Well, since we are online, I think maybe we can continue, but maybe we can use this time for questions. Anyone has a question, just to remind you that there is a chat box and also a Q&A box at the bottom of the screen. Also, you can wave, so I can make you talk also on this presentation. You can connect with us. So anyone has a question, just let us know.
Okay. All right.
Yeah, I think we had a question here. Is Lynn? Let me just check here.
Oh, do I?
Yeah, we have a. Hi, Lynn. I think Lynn has a question here.
Okay. I hear you, but I don't hear Lynn.
Check here. Maybe Lynn has no microphone.
Oh, maybe. Maybe
probably, yeah.
maybe
So
she can type it in.
yeah, it seems that she doesn't have any microphone. Or,
Oh,
let's chat with.
there's
So
something.
someone asked, what? Yeah. So so R. Calhoun asked, what is a SSRI?
Oh, okay. Yeah, an SSRI is a class of antidepressant medication. They're called the serotonin-specific reuptake inhibitors. So they are one class of antidepressant medication. So it was just used as an example of one of the treatments that we might give to give for depression. It's a common class of antidepressants used and acts on that serotonergic system, which is one of the neurotransmitters I talked about in one of the slides. Does that help?
So Lynn has a question, but we cannot connect now. Maybe we can leave it to the end.
Okay.
Hello? Hello? Are you there? So someone asked, can we get a soft copy of the presentation?
Yes, I believe we are going to mail out, right? We're going to mail out.
Yeah.
We're going to send out.
We're gonna mail out all the to all participants the slides. Yes.
Yes.
So anyone has another question? So just to remind people that we are connected through Zoom platform, and we also are connected with on Facebook Live. So hello everyone to who are connected also on Facebook. They're following us on social media. So Dr. Lisa Sweet is having a presentation about understanding behavioral and psychological symptom of dementia. So I think we can continue, and if you have any questions, you can. Yeah, there's someone here. I think I can see Lynn now.
Okay.
Yeah, so I don't know why I cannot talk to her.
Okay.
Anyways, let's continue, and
Okay.
maybe Lynn has a question.
Yeah, or she can write it in, or she can even send me an email. Okay. All right. So we're going to continue.
Okay.
Right. Okay. So the next part we're going to talk about is the behavioral and psychological symptoms in different types of dementia. So I'm going to touch upon vascular dementia, Alzheimer's, and other forms of dementia, just to highlight some of the things that can come up in those dementias. And I think what you'll notice as we go through them is that there is a great deal of overlap. There isn't, things like apathy, depression, anxiety. We said at the beginning that they were the most common ones, and they are because they happen in many of the forms of dementia. But just to touch upon each type, so you get a sense of what might be more prominent in one form of dementia versus another. So the first one we're going to talk about is vascular dementia. If you remember a few slides ago, I talked about the fact that vascular dementia was harder to predict because it depends where the vascular injury occurs. So when someone has vascular dementia, they have had either multiple strokes of mild or moderate strokes, or sometimes the person might have had one very significant, what we call strategic stroke, which in and of itself resulted in enough cognitive and functional change to be labeled vascular dementia. So depending on what type of stroke you had or where the stroke occurred, so where the injury occurred in the brain, that will affect the presentation of the person. And that in turn can affect what type of behavioral or psychological symptoms you might see. So vascular is a little bit even less predictable than the other forms of dementia. Things that are perhaps more common in vascular dementia are mood changes and disruptions in sleep patterns. That's something that can come up quite a bit. And when we've done some studies, or when they've done some studies to compare individuals with vascular dementia versus individuals with Alzheimer's disease, you might see a higher rate of depression, agitation, and what I refer to as those aberrant motor behaviors. So disrobing, wandering, banging, and the sleep disturbances. Again, those things are not unique to vascular dementia, because you'll see I'm going to bring them up again in other forms of dementia, but they just might come up often in vascular dementia, again, depending on how significant or how progressive the person's strokes or vascular insults have been over time. Okay, so that's vascular. Oh, this one here, this slide here just talks about that emotional lability. So one of the things that can happen with vascular dementia, as I mentioned in the previous slide, is that you might get a little bit more emotional change. So lability refers to usually a relatively sudden and intense display of emotion, and it's much greater than you would expect for that person, again, because you've got to think of the person's premorbid personality. So it's kind of out of character for that person. And it's usually much greater than what you would expect given the particular situation. Okay, so we might be talking about something that is not sad or particularly distressing to the person, and they might suddenly burst into tears and just not be able to control their tears at all. And some people might feel quite embarrassed by it, as a matter of fact, because they can't quite get control over those emotions. It may stop then as suddenly as it started, whereas somebody who really has that emotional where the expression of the emotion kind of fits with the degree of emotion they're experiencing, it's kind of harder to move on. If you're feeling really, really sad, then in the middle of a conversation, I can't really switch you off to something else as easily. So when it's emotional lability, it's much more superficial, and it can stop as suddenly as it started. At times it might be inappropriate for the situation. The person might be unable to control a sense of laughter in a very perhaps sad or difficult situation. And it seems kind of not fitting to what's going on. And as I mentioned, the internal emotional state will be much less intense often than what's being expressed behaviorally. And this is something that happens often in people with neurological conditions. They can't control it as well. It's really, and like I say, it can become embarrassing for them because they might burst into tears or burst into laughter when they really did not intend to and really didn't feel that way, didn't have the emotion to go with it. So emotional lability is something that is quite common in vascular dementia. So moving on to Lewy body dementia and its kind of behavioral and psychological symptoms. So whereas throughout this talk, I have said that these symptoms, behavioral and psychological symptoms, occur or become more prominent in the later stages of dementia. For Lewy body dementia patients, they can start to appear a little earlier on. Anxiety being one of the most common ones reported, depression, apathy, agitation, and sleep. You have some percentages there thrown in. Those can come up earlier on. And psychosis is present often earlier on in the disease, and I'm going to talk a little bit more about that. The psychosis in this case mainly being visual hallucinations. That is one of the defining diagnostic criteria of Lewy body dementia early on in the condition. So for Lewy body patients, they can experience kind of a broader array of symptoms early on at the beginning of the disease when I think of comparing them to Alzheimer's disease. They can have the cognitive changes, so they'll experience problems with processing, problems with memory, but they often also experience motor symptoms, so they might have a few features that look a little Parkinsonian in terms of their physical mobility. They can experience perceptual difficulties. So I'll see a lot of visual spatial troubles on testing. And perceptually, they might begin to see things that are not there. And the emotional symptoms can appear earlier on, as I mentioned, the anxiety. In Lewy body dementia, the other thing that kind of defines this dementia more than others is you will see much more of a moment-to-moment fluctuation in the person's level of functioning. So people with dementia, like the rest of us, have good days and bad days. And that's normal. That won't help me distinguish one from the other. But people who describe individuals with Lewy body will often come in and say, you know, they really change from day to day, or from, you know, an hour ago she seemed fine, now she seemed muddled and is staring out into space, and then boom, she seems much better. So you're going to get much more fluctuations in Lewy body, and that's one of the manifestations that we will look for in that disorder. So with psychosis being something quite common in the early stages of dementia, it is most often in the form of visual hallucinations. Other forms of hallucinations, auditory, hearing things, much less common. That is much more typical of kind of a psychotic disorder such as schizophrenia or something like that. Whereas individuals with Lewy body who have no previous history of psychosis or psychiatric disturbances can start to experience visual hallucinations. It's a very common and early symptom. Oftentimes it's little animals, cats, mice. They might see people. Oftentimes it will be scurrying across the floor. They are vivid. They can see them very well. It's not just, I think I saw. They're well formed. They can occur more often in the evening because of what we discussed earlier, but they can occur during the day. And often they're not disturbing to the person, and they might not mention it until it's asked of them, where they'll say, well, yeah, you know, I often see a cat at home, and I know we don't have a cat, but God, he looks so real and I see it. Ask them if it bothers them or worries them. It's like, no, it's a little odd, but I'm not afraid of it. They're not frightening. So they might not be distressing to the individual, but they're certainly there very often in Lewy body. So this part here talks about, so I'm talking about very vivid and formed visual hallucinations, but they can also report what we call our visual illusions. And those will be just misperceptions. We know in Lewy body, there's often visual spatial difficulties. So the person might experience difficulties with their depth perception, the orientation of objects, their sense of direction. So they may often misinterpret what their eyes are seeing. The brain just can't make sense of it the same way. And that can precipitate looking more confused, and of course being a little bit more anxious and agitated. And there is an increased risk of falls. Falling early on in the condition is also one of the features of Lewy body dementia. If somebody comes in and describes somebody who is, his memory or her memory is starting to fail, and they're reporting new onset of visual hallucinations, and they've had a couple of falls, the first thing on my list that I'm thinking of is possibly Lewy body dementia. So those are some of the defining features. And perhaps of all of the dementias, if I think of vascular, if I think of Alzheimer's disease, Lewy body dementia is the one where you are more likely to see those psychological symptoms appear early on. The anxiety, the depression, the unusual beliefs, and some of the visual hallucinations. People with Alzheimer's disease can experience visual hallucinations and certainly have some of these problems, but that would be typically much later in the disease process. Delusions in Lewy body are something that come up quite often. So what is a delusion? A delusion is a false belief to which you will hold on to despite all the evidence. The thing about delusions is you can talk to the person and try to rationalize with them and show them that it's not true or that it doesn't make sense. But by definition, a delusion is not rational. So approaching it from a rational way is virtually unsuccessful most of the time. You're not going to convince the person because they're just not seeing it the same way. They're just not analyzing the information in a rational way. So people with Lewy body can often experience delusional beliefs, sometimes earlier on in the condition. And the form of delusions might take on different flavors. They might become a little paranoid. They might think that people are out to get them. And you might even see things that we call delusional jealousy. Other types of delusions are what we call misidentification. And I have a slide that's going to show you what some of those misidentifications are. But generally, it's a belief that the identity of a person or an object or a place has somehow changed. These are syndromes. I mean, Capgras syndrome, I think I've seen one very clear Capgras, but it can happen where the person will start to believe that another person has been replaced by an imposter. And you'll see here on this next slide, I explain a little bit more about those things. So a misidentification is really a perceptual disorder. They are misperceiving external stimuli, whereas a visual hallucination, they are seeing something that is not there, that if you look, you will not see the cat or the mouse or the spider on the wall. Whereas a perceptual disorder, they're looking at something, but they're misperceiving it. And oftentimes it is associated with a belief related to that misperception. Some of the ones that those of you who provide care to people perhaps with more advanced dementias or Lewy body dementia, perhaps earlier on, are things that we call phantom boarder. People will become convinced that there's someone in the house with them, even though there might not be. They can look at their own reflection in the mirror and not recognize it. And they might misidentify someone else, such as in the syndrome of Capgras, where they think that someone they know has been taken over by an imposter. So it might be that I say, you look like my husband, you sound like my husband, but you're not really my husband. And there are times when people will misidentify, misinterpret, misperceive events on television and believe them to be true and happening to them and happening now. So things like watching a soap opera, people can get caught up in that and really starting to not only misperceive, but misbelieve what is going on. So those are just some examples of misidentifications. Tied and related to that are the delusional beliefs. So as I said earlier on here, those perceptual or misperceptions of the external stimuli, the external things, are often associated with a belief, and that belief can become delusional. Oh, I see a typo here, sorry. People are stealing things. If you can't find your stuff because of, well, your memory impairment, but you can't find it and you don't know or don't have the awareness that you have a memory impairment, the logical reasoning is that people are stealing things. So the belief that people are stealing personal items is a very common delusion in dementia. The sense that this is not their home, the house is not mine, which can lead to maybe some of the exit-seeking behavior. This delusion that the spouse or a loved one is an imposter. People can become delusional about a fear of abandonment or the delusional jealousy of or infidelity, start to believe that their spouse has had an infidelity, even though it might not be true. All of that can become quite difficult to manage as a caregiver when you cannot get the person to see it in a rational way. You simply cannot convince them otherwise. One of the other issues that comes up in Lewy body is what we call the REM sleep behavior disorder. So when we go to sleep and when we fall into REM sleep, we are in a normal situation, you cannot act out your dreams. I'm not talking about sleepwalking, that's a whole different phenomenon, but when you're in REM sleep, you don't act out your dreams. There's a process that happens where your muscles just don't work. What happens in people with REM sleep behavior disorder is they can. So they will often have vivid dreams during the REM phase of sleep, and behaviorally, they can act out those dreams. So people will talk loudly, will often move violently, can go so far as falling out of bed. There are situations where they can hurt themselves, they can hurt their sleeping partner. We have people who have to sleep in other rooms because of being kicked or punched or, pushed out of the bed. The person will often experience increased confusion when they wake up. They won't necessarily remember that as having happened. And when you put all that together, that is when someone is experiencing REM sleep behavior disorder, it's not always going to be linked with Lewy body dementia, but it is certainly a risk factor. For us, it perks up our ears, and it could be several years before the dementia actually manifests itself that the person started to experience this. So often as we question people, because now they've come to see us about, say, their memory impairment and maybe visual hallucinations, we might find that, for the last year or two, they've also been experiencing this wild sleep behavior. So that is one of the disorders that can happen in Lewy body dementia and become quite disruptive as well. As I touched upon earlier, I won't spend too much time, but fluctuations in Lewy body dementia is one of the core criteria. It's not necessarily sundowning. It can happen at different times, but there'll be a lot of fluctuation in their cognition and level of alertness. As I mentioned before, Lewy body disorder can be associated with a lot of changes in mood. So we might find some of that apathy. We might actually see some of the depression as well, anxiety and aggression. Okay, moving along, I am conscious of time. So moving along to frontotemporal dementia, this is where you will see much more behavioral disturbances from the get-go. It is the defining feature of the behavioral variant of frontotemporal dementia is behavioral change, and it doesn't come at the end or the advanced stages of dementia. It is the early symptoms. People will present with impulsivity, a loss of social judgment. So think of the frontal lobe I mentioned to you earlier. Your frontal lobe is kind of the CEO. It allows you to be to properly inhibit behavior, to have goals, to have insight and awareness. And in frontotemporal dementia, the frontal lobe is often where the disease strikes. So you'll start to see some changes there. So the first symptoms might not be memory, as you'll see in Alzheimer's disease. It'll be that loss of social judgment, impulsivity. And people will come to us with sometimes more subtle. They'll just say, she's a little off, not herself, but oftentimes it'll quickly escalate to much more notable behavior changes. So people might start to behave very inappropriately, and that's way out of character for them. They might make jokes. We've had people say, geez, he's just started urinating in public, like doesn't care. People will do impulsive shopping, gambling, drinking, stealing, a lot of hypersexual behavior. So really behaving in a way that is not typical of them and represents kind of a change in their personality and their demeanor and their social judgment. That will happen very early on in frontotemporal dementia. Other behaviors in frontotemporal dementia will be what we call hyperoral behaviors. So all around eating and dietary changes. There might be overeating, excessive consumption of food, changes in food preferences, often for sweets and carbs. People don't suddenly start loving broccoli and Brussels sprouts, but often carbohydrates. They might pick something and become quite compulsive about it. I had assessed a patient who seemed to have this real focus on pineapple. So they might restrict and start eating only specific foods. It could get so far as trying to eat inedible objects, though perhaps less frequency. And as a caregiver, that becomes very difficult to manage. People have resorted to kind of hiding food, locking the refrigerator, but then you get into somebody who might be disinhibited and it's like, okay, well, if you're going to lock up everything here, we'll have no qualms about going down to the corner store and maybe even stealing a candy bar, because their social judgment is just not where it once was. So hyperoral behaviors, what we call food fads, changing in food preferences is one of the defining features of frontotemporal dementia, and again, can occur fairly early on in the disorder. The last two slides, what I've described are kind of the behavioral variant, where I've talked about kind of more that outlandish behavior, that disinhibited behavior. We can see the reverse in frontotemporal dementia, where the person will actually be much more apathetic. So there'll be a flatness, a lack of caring, a lack of empathy. People don't react anymore to things that happen perhaps to their children. That might be one of the first signs. They'll say, my son was really sad and my wife just didn't care, and that is not like her at all. They might come across as more self-centered, and they lack the insight. They do not see it as a problem. I may ask them about the problem and they'll say everything is just fine. They're not quite sure why everyone is making such a fuss. Other things in behavioral variant FT or frontotemporal dementia are stereotypical behaviors. So what we call stereotypies, where the person will just repeat behavior over and over and over again, checking locks and doors, start hoarding items, collecting items, counting over and over, clapping, throat clearing can be one of them. So you just get these repetitive behaviors, repetitive movements, which can become very, very difficult to deal with day to day as a caregiver or as a healthcare professional. One of also the earlier changes in behavioral variant FTD is, again, because the frontal lobes don't function, our sense of social awareness, what's appropriate, what's not, is the people might start neglecting their personal hygiene early on in the disease, or might develop rituals of hygiene or dressing, become very, very rigid and inflexible, is what can happen in behavioral variant frontotemporal dementia. I have a few more slides here. I'm conscious of time. I don't know if people have to sign off at 8:30. I'm going to keep going a little bit. We started late. So here we have some of the behavioral and psychological manifestations that you can see in Parkinson's disease. Again, depression comes up quite a bit. A slowing, that loss of energy, all of that stuff, which kind of forms part and parcel of depression. And anxiety. Again, those are the ones that I said would come up the most often, and they do cut across. Parkinson's and Lewy body are related. They both fall in the category of what we would call a Parkinsonian type of neurological disease. So as with Lewy body dementia, where I said at the beginning, you might get more of the psychological or psychiatric symptomatology. Same thing holds true for Parkinson's, because they are related. You can get psychosis in Parkinson's disease as well. So, you know, hallucinations can come up as well, just not as often as somebody with Lewy body dementia. So here we have, I've just compiled a list or taken from one of the behavior guides to help out as caregivers or even as a healthcare professional. Things to keep in mind is just a little list of things that we do, or things in the environment, because we're part of the environment, that can exacerbate some of the symptoms that you'll see or some of the behavioral problems you'll have. I won't go through the whole list, but, you know, sudden and unexpected changes in the routine, that's often a big one. Getting into power struggles for things that might be less important, and placing excessive demands on the person when they cannot meet them because they've lost the ability. Those are kind of the top three, and probably some of the hardest to navigate. Figuring out when somebody can and cannot, as opposed to just won't get started, is not always easy. But there you have a list of things that I'm sure all of us, I have certainly as a healthcare professional, experience, and I'm sure every caregiver can identify with, but they are the things that are more likely to exacerbate the behavioral and psychological symptoms. So if there's a way of curtailing these in any way, we're more likely to maybe not just get entangled in the problem. You also have to counteract that. We have a list of things that can help alleviate the symptoms that the person might experience, and that become such a heavy burden in providing them with their care. So again, I won't go through all of those. They're pretty self-explanatory, but you've got that list to access if you need it. So just to wrap up, we wanted to talk about these things because at the beginning I mentioned we know they're there, and really often we talk about the cognition and, you know, whether it's a mild or moderate cognitive disorder, but we know that the behavioral and psychological symptoms are so important, and that the cognition is really, as I showed you, the tip of the iceberg, and how it's important to be aware of and address and try to help families or caregivers with the behavioral and psychological symptoms, because it can take such a heavy toll on them as well, psychologically and physically. As a caregiver, it increases distress, depression, anxiety, anger. I mean, people don't like to talk about feeling angry. We like to talk about, or we feel okay talking about feeling distressed or depressed, but angry and resentful, and having poor sleep, and creating family conflict. And then the physical health of the caregiver can be compromised. It can create kind of primary changes, right? If you're stressed all the time, people can develop high blood pressure, but also the more stressed we are, the less likely we are to engage in our own self-care and our own, you know, healthy behaviors, and we become unhealthy. We don't sleep as well. We don't exercise as much. We might smoke more. We might drink more alcohol. We might not see our friends as much. And all of that will have an impact on the family or the caregiver's health as well. And if the caregiver burns out, then it's just that much harder to care for the person with dementia. So in conclusion, I just want you to remember that the difficulties displayed by the person with dementia is often due to multiple factors, including the changes in the brain. Typically, the person might not have as much awareness or be as able to control the problem behaviors. So when we think about to what we're going to attribute the behavior to try to think of the broader situation rather than to the individual intent. And planning ahead and learning how to manage these behaviors will help kind of ease this journey. So I think there's a few additional slides, but we're going to get into management next week. So I'm not going to touch upon those tonight. I think we can end right here on the conclusions, and I'm happy to take any questions or comments if anyone has any.